Hello, everyone. I'm Sherry Rolfing, your host of the ACAP D-SNP MLTSS MA Showcase, the first in our Medicare series. I'd like to welcome you today to our session presented by Siftwell about opportunities for D-SNP LTSS MA plans leveraging AI to level up. But before I get started, I have a few housekeeping items. This session, along with all ACAP calls and webinars, will be held in accordance with the ACAP antitrust guidelines. These guidelines can be viewed on our website. We'll record today's call and we'll post it and the slide deck on the event showcase. Always remember, if your plan is seeking services, be sure to check out our list of preferred vendors, just like Siftwell, on our website. Look at the top of our homepage and click on the preferred vendors link. You can also post a note or even an RFP on the preferred vendor connection portal. During today's session, you can ask a question at any time by clicking on the Q&A icon in your Zoom window and typing in your question. All questions will be answered during the session. Now I'd like to introduce Christine Aguiar Lynch, ACAP Vice President, to kick us off.
Thank you, Sherry. And on behalf of ACAP, I just wanted to say a very brief welcome. We are delighted to bring you all this vendor showcase series, which is part of our operational support to our D-SNP members. And this series is really an opportunity to highlight all the vendors out there that support ACAP's member plans in the D-SNP space. So we are delighted to have Siftwell, an ACAP preferred vendor, present today. And with that, I will turn it over to Trey.
Awesome. Thank you, Christine. Welcome, everybody. Delighted to be here to talk a little bit about what's happening in the space, talk a little bit about how Siftwell is working with some of our plan partners. And then most importantly, we really want this to be helpful and useful to everybody listening in. And so we'll leave a good portion for Q&A. What I wanted to do, though, to start is really give everybody on the webinar to do a quick introduction, tell you all a little bit about their backgrounds. We're super fortunate to have, in addition to our partners at ACAP, we've got Mary Kaschak with us from the MLTSS Association, who's an expert in the area. She's going to set some of the foundation for the conversation. So, Mary, do you want to start with an introduction? Then we'll go to you, Eben, and then I can go after that.
Sure. Thanks, Trey, and thanks, Christine and Sherry, for hosting this webinar, and Trey for the invitation to be part of this. I'm Mary Kaschak with the MLTSS Association, and we are an association of plans that are really focused specifically on advancing managed long-term services and supports and integrated care for dually eligible beneficiaries. As I'm sure folks who are on this call are all well aware of the unique challenges that MLTSS plans face. It's not just your traditional managed care services when you're working with these really complex populations and dually eligible consumers who are eligible for both Medicare and Medicaid. And so we're really focused on specifically addressing the unique challenges that plans and consumers experience in this space, and happy to be part of today's webinar.
Thank you, Mary. And I won't even try to pronounce Eben's last name since I didn't get yours right. So Eben, you want to go next?
Good afternoon, Eben Esterhuizen, CTO and co-founder of Siftwell. Thank you very much for making the time for us today. I am a data scientist, and I've worked in the industry many years in finance, marketing, and most recently doing consultancy for big tech companies, focusing on behavioral modeling. So using the latest data science and machine learning techniques to predict attitudes, change those attitudes, and then ultimately change behaviors for consumers and big tech ecosystems. And it felt very natural to take those mathematical frameworks and apply it within a healthcare setting. And that really was the beginning of my journey with Siftwell. It's been a fantastic journey, and very excited to talk to you today about how we're using the latest and some of these amazing technologies to provide very relevant care to these members.
Thanks, Eben. And again, Trey Sutten, great to be with everybody today. My background, spent over 20 years in healthcare, really got deep into Medicaid, in particular as the CFO for Medicaid in North Carolina, and then went on to be the CEO of an ACAP plan. We had about 1 million members, including a lot of folks that were covered by MLTSS services, was also on the board of ACAP, as well as MHPA. Started Siftwell about 2 years ago, or started full-time with Siftwell about 2 years ago, and work with our ACAP plan partners to help them improve in a number of different areas, which we'll get into in a few minutes. What I thought what we would do, though, is start with a little bit of foundation setting. A lot of folks on the call today, maybe single state plans, aren't seeing things from a national perspective, and really want Mary to kick us off with a little bit of a preview about what's happened nationally, what some major challenges or major opportunities are for MLTSS plans. Mary, do you want to get us going here?
Yeah, sure. And thanks for that. I think, with more than half of states now offering MLTSS programs, some of the challenges that we're really seeing are the differences among the states in how they are setting up and designing their programs. So there is a lot of diversity in terms of the populations that are carved in or carved out of MLTSS at the national level. There are differences in terms of the services that are being provided within an MLTSS program, as well as the reporting requirements for MLTSS plans and their providers. Specifically, as we're talking about quality measurement. Now, although there are some quality measures and even some that are new coming out of this most recent HCBS access rule that was just recently released, quality measurement within the MLTSS space, and specifically the HCBS space, is still the wild, wild west. There is no standard set of quality measurement that is being collected on a standard basis. And so that's really a challenge when it comes to you all as plans and providers trying to develop and scale meaningful MLTSS programs, as well as setting up things like value-based contracting within an MLTSS structure. We know that these MLTSS populations are really, really unique in terms of the services that they're getting and the requirements for person-centered planning. And to isolate something around, a value-based contracting without a standard set of nationally recognized quality measures is still really challenging. But we are seeing some progress that states and plans are starting to make in this space.
Awesome. Thank you for that, Mary. And what we're going to do next is, with that as kind of a backdrop of what's happened nationally, what we wanted to do is tell folks a little bit about what Siftwell's up to. I don't want this to feel like a commercial, but I think it's an important foundation setting so that folks understand what we're up to and kind of where the team and the idea came from. So I'll be brief in kind of the commercial part, and then we'll get into the meat of what we do and how we help plans. Siftwell, again, was founded by and for managed care leaders and operators, true operators. So this isn't about developing a set of predictions, throwing it over the wall and crossing our fingers that our plan partners implement some of it. It's really about bringing that managed care expertise and combining it with the latest in artificial intelligence tools that I didn't realize existed before I joined the company. A lot of the work that we were doing back at the plan was either, risk stratification was either dictated by the contract, or we had set things up that were correlational and retrospective and kind of identification of where we were experiencing risk. And what we're doing is entirely different. And frankly, really wish I had some of these tools when I was back running the plan. We do a couple things in particular for plans. We identify members with increasing risk, and that can be defined as either progression of a certain disease state or complexity, or in terms of the associated care cost, in particular unnecessary care cost. We give our plan partners situational awareness, where their members are, how those supports and services are aligned with them, and then how to drive congruence between those supports and services and what folks are experiencing. And then the other two areas that we really focus on is quality scores and member outcomes. And then lastly, improving financial performance. And that can be done both by reducing unnecessary care costs, or if a plan is risk adjusted or wants to identify ways to hold on to more members if they've got a churn issue. That's another area that we focus on. I mostly covered this. Again, we touched population health, risk adjustment, voluntary disenrollment, And then this says HEDIS, but I would think about that more broadly as quality scores. Before we do those, we do establish situational awareness with all our plan partners. Again, where are your members? What are the conditions that they're facing? What are the current cohorts by various levels? And then as we identify opportunities to move the needles on these 4 areas, we also do longitudinal tracking and actually partner with the plans, stay with them, do campaign planning and implementation, and then how are those things bending the curve, whether that's holding on to more people or adjusting kind of HEDIS measures. In terms of how we do that, it starts with data collection. So we work with plans to get at a minimum their claims information, but it often goes past that. We'll collect customer satisfaction. If it's an ACA plan or where there are premiums, we'll collect premium payment history, call logs, health risk assessments. I mean, you name it. If it's on the shelf, we'll take it, and we'll take it in our plan partners formats. And so that reduces a little bit of friction on the onboarding. From there, we stitch that data set together with ones that we built or sourced. So think about a member's access to food, social connectedness, transportation, proximity to health systems or other healthcare providers. You name it, we pretty much know it, with the exception of credit card data. From there, we run it through a couple of different layers of machine learning and artificial intelligence, with the idea of identifying those with either emerging risk or facing some of the other challenges or opportunities that we've talked about, and then really contextualizing them. And that's what comes back in addition to the partnership when we do the reports. So just to step through kind of a specific example, this is an emerging cost analysis for one of our plan partners. Here, what we've done is we've identified 4,000 individuals that are going to come out of the shadows in terms of their cost increases. They're plotted vertically according to how much on a per member per year basis they're going to increase. And then horizontally, they are plotted according to density. And that's a measure of, or is it 6 out of 10, 8 out of 10, 10 out of 10 individuals inside of each one of these profiles are going to rise in terms of those costs. And then the diameter of the bubble is the number of individuals inside of each one of these profiles. I think it's important to mention here that when we say profiles, these aren't arbitrary kind of variables that we've drawn ring fences around. So it's not like, here's a demographic group or here's a geographic group. These are profiles or cohorts of individuals that naturally emerge out of the underlying data in related factors. Either these are the obstacles that they're facing, these are the conditions that they're facing, or this is the claims pattern, something like that. And these naturally emerge out of the machine learning. Then we use artificial intelligence to contextualize them. So if you were to click on one of those dots, for example, you'd move from that big number of 4,000 down to a group of 90 roughly that are predominantly new members to the plan, predominantly female between the ages of 60 and 65. They're going to move from an average current cost of $2,600 to $20,000. About 80% of them are going to receive a first-time diagnosis of type 2 diabetes, but they're also showing up as high risk for a couple other conditions, including obesity, hypertension, lipoprotein disorders, and back pain. They live in areas with low technological adoption and low levels of computer ownership, and so an email campaign isn't going to work here. They've got low levels of medication adherence, but they are interacting with the healthcare system. In fact, I've been to a provider in the last 90 days. And so there is an opportunity to get in touch with these folks. So that's the contextualization piece. The only other thing I would mention is that, in running the analysis on, we build and train our models for each plan individually. And this is a really important thing, particularly when you're talking about unique populations, and whether that's a foster care population, MLTSS population, or some other group. Nuance in the data emerges that allows for better prediction and better contextualization. What you've got in front of you on this slide, and I promise I'll finish after this, is us as compared to a national model. And this is Johns Hopkins. And so what they've done here is they've run their predictions. Our client asked us to run ours and then compare. And on a back-tested basis, we were able to identify cost by a factor of 2x more accurately than Johns Hopkins. And so our top 500 actually cost the plan on a back-tested basis $21,000 versus $10,870. And you can see the pattern repeats itself on down those various cohorts. But on the right-hand side, you can see where that emerging risk is coming from in particular. A vast majority of them, almost 50% of them, were identified as moderate using models that weren't trained on this specific population, but that ended up actually being high cost. And so you can see here a lot of nuance comes out of special populations or unique populations. And this just kind of demonstrates where that risk is coming that other models otherwise would have labeled as moderate. So hopefully that's helpful context for what we're up to. And from there, I want to go back into the market, the plans that are serving these individuals, and some of the particular trends that are emerging right now. So Mary, one of the big things that folks are talking a lot about writ large across the healthcare industry is equity. And I know that's touching this area. Can you talk to me a little bit about what you're hearing from your plan partners, how they're thinking about equity in this space and what they're doing?
Yeah, so we all know, right, that there are multiple factors that impede efficient and equitable healthcare, including their workforce challenges, transportation issues, the healthcare costs themselves, language barriers, limited health literacy, and other complexities just related to the health insurance coverage and process. And then you have social determinants of health and community level burdens that contribute to the exacerbation of health disparities. There is also oftentimes a connection between healthcare fraud and abuse and health disparities. Again, I think it's really important to acknowledge the broader context in which MLTSS programs exist that I mentioned at the beginning of this is, before we can even discuss the intersectionality of these things, it's really important to note that the whole population of people with LTSS needs can experience inequities due to the inherent ableism and ageism that exist in our society. And because of the Medicaid LTSS eligibility criteria and covered benefits vary so significantly by state, there are inherently structural inequities in access to services based on geography, age, and disability type. While we know health equity affects many different populations, we know that those disparities within the LTSS populations are even more pronounced because the disability status often intersects with other historically marginalized identities like race and ethnicity. And it might not be as apparent to others within the healthcare industry how prominent this really is within the LTSS sector. Dually eligible beneficiaries are also known to be really low income by definition, racially and ethnically diverse, and have particularly complex care needs, with about 50% of dually eligible consumers receiving or needing LTSS services or in-home services and supports. So first, I think we're really focused on, how do you make the connection more between health equity and disability and bring these populations to the forefront of some of these conversations with that recognition that they do experience inequity at higher proportions, or it's sometimes exacerbated within the LTSS population. We're also really focused on the impact of workforce challenges on disparities and outcomes. We know workforce challenges are pervasive, but they're even more dire in hard to serve regions due to rate issues, challenges with recruiting, public safety concerns. They're even harder to staff in rural communities compared to more urban settings. And there are provider deserts where providers are leaving and there just aren't services available, which obviously affects access to MLTSS in historically underserved areas. To understand inequities, MLTSS plans really have to authentically engage their members through multiple modalities. A lot of MLTSS programs have requirements around engaging and educating MLTSS consumers, but there are definitely opportunities to better engage those with lived experience and to better engage members within their care. It's also really hard to address equity if the MLTSS plans aren't sure how to measure it necessarily. They might not have the measurement or the data that is needed to really address the inequities within their populations. So these are some of the things that we're talking about and that we're focused on with MLTSS plans in terms of really elevating LTSS recipients as a broader as a priority population in these broader conversations around health equity, recognizing the impact of social determinants of health is often exacerbated within these populations, and wanting to address inequity, but needing to be able to measure it first or have a sense of the inequities that these populations are experiencing.
Right, that's super helpful context and very important issues. Eben, you've been in this space a long time. I mean, one of the main criticisms or concerns, I should say, about artificial intelligence is the propagation of biases and how you combat that. Can you talk a little bit about the technology and how you think about it, what you've seen, and maybe what's different now about the technology that prevents some of that bias from showing up in the work?
Yeah, I think we've all heard of a recent lawsuit that involved, a machine learning model that was essentially using correlations and claims data to allocate risk to a population. And, the example there was very clear. White people, they tend to be more engaged with the healthcare system. They tend to go to the doctor more often, and they would have higher volumes of claims in the data sets that this correlational machine learning engine was using. And because they had higher volumes of claims, the engine would basically say they are higher risk, give them higher levels of care, that then perpetuated the biases that existed in society. So all the examples that Mary listed, distance, literacy, cultural concordance, all those factors limiting the engagement for that population. And most of the time, that ends up creating worse outcomes for those populations that are being biased by that correlational machine learning engine. Now, a couple of years ago, most of these machine learning models were black boxes. They were just signals going in, black box generates a prediction, and no one could really understand what was happening inside this engine. And that was part of the problem, that the machine was just picking up these correlations that were just perpetuating the societal bias. And that obviously presented a huge challenge to the industry. A couple of years ago, a big breakthrough in what's called explainable AI. So there are now new techniques where you can actually interrogate the model at the member level to have the model explain to you, for this individual member, why is it generating this prediction? Is it because of STOH? Is it because of workforce challenges? Is it because of literacy, safety, services and support, medical adherence, and so on and so on? The machine can tell you for each individual why it's generating that prediction. And very critically, it can also come up with what's called counterfactual scenarios. It can actually tell you, in order for this person to go to a breast cancer screening, for example, these are the things that need to change. And that becomes very powerful when you combine that with causal AI, because with causal AI, you can actually identify the root cause of the problem, which usually is a very separate type of driver from a correlational driver that then automatically controls for a lot of the bias that we have in these data sets. So here at Siftwell, we're very excited about the potential of using explainable AI with causal inference to actually solve some of the perpetual societal biases that we have, and to actually lead to more effective, equitable care to these populations that need it. So hopefully we can talk more about that in the future, but that's definitely a recent development that we think can really help address this health equity challenge within these very complicated populations.
Yeah. Good. Thanks for that, Eben. The things I would add to round that out a little bit as well, Eben, is like, there's all kinds of checks that Eben does on the inbound side and on the outbound side with as it relates to proportionality. How many women are we seeing inbound? How many are showing up in the predictions? How many of different different categories of disability groups or whatever it is, but there's proportionality checks on both the inbound and outbound side. I don't know if you want to add anything there, Eben, about some of what else happens inside the box.
I mean, I think the general quality control makes a lot of sense. I think very critically too, it's very naive to think that a machine can just do everything end to end. That might be true in some industries like finance and marketing, but that is definitely not true in healthcare, where you need a human in the loop to be a part of the decision. And I think one of the benefits of using a causal framework is that it is this collaboration between humans and machines, experts in the field talking to these members, asking them, how are you feeling at home? Do you feel safe in your food security? Do you feel, safe in your home place? Having those types of human interactions feeding back into the machine to augment this causal engine, we consider that to be a critical aspect of the engine. And that's very core to the way we work with our clients and how we manage these campaigns, that it really is this collaboration between the signals coming out of this engine, trying to address the inequities in the system, and humans trying to make a difference in the real world and trying to see if we're actually making a difference on these campaigns.
Yeah. And Eben, I'm glad you mentioned the human in the loop part. One of the other ways to effectively combat bias or kind of the bad uses of artificial intelligence is in the deployment, development of these technologies. One thing, the deployment and how you use it, how you apply it in the real world is something entirely different. And that's why, having been the CEO of an ACAP plan, been on the board, love the partnership that we've got with Christine, Sherry, Meg, everybody else there. But ACAP plans have that mission orientation, and Mary's got the same luxury at her association. Plans that really care about their members and want to use these technologies for making the universe a better place, and in particular the members that they're serving. So I think that's another really important aspect, and frankly why 75% of our clients are ACAP plans. Mary, I want to switch and go a little bit more specific because there are two things that we're working on with some plans right now that are really exciting and interesting to us. One is on the retention side. Some of our plan partners experience high levels of turnover. And then another one has asked us to do some work around risk of institutionalization. Can you talk a little bit about what do those things mean? How focused are plans on those issues? And then what are you hearing about as it relates to those two issues?
Yeah, so both really, really important topics and things that we know plans are grappling with and trying to tackle. You talked about member retention. That is critically important for all managed care organizations. But when we're talking particularly about MLTSS populations and dually eligible populations, plans want to make investments right in those populations, but you don't often see an immediate impact on investments in the services that you're providing. And so it's really critical to be able to maintain those members long-term or year after year to see the impacts of the investments in the services that MLTSS plans are making. And one of the unique challenges, I think, to member retention and items that are causing some member abrasion within some plans, it is around the dually eligible population and policies, both at the federal level and at the state level, around the alignment of the Medicare and Medicaid benefit. So the majority of dually eligible consumers are in what we call unaligned plans or in an unaligned market. So you have some states, for example, like Pennsylvania, where all dual eligible consumers were carved into MLTSS for their Medicaid coverage. But they're seeing increasing expectations from the state in terms of being able to provide and care for things that maybe Medicare should be covering. And it's really challenging. And we're seeing that across a number of states where there might be this misalignment of expectations because you have dually eligible consumers enrolled in an MLTSS plan on the Medicaid side, but they're in Medicare fee-for-service or they're somewhere else on the Medicare side. And it can help, and it can create member abrasion because of the challenges that is experiencing. And when you have this misalignment, you often have members who might be switching plans to find alignment. And so member abrasion is definitely a huge challenge for MLTSS plans, and I think for D-SNPs as well, because of not limited to, but one of the major factors I think contributing to this is the unalignment of care for dually eligible consumers, which make up a vast majority of LTSS recipients. So maybe I'll pause there and just see if you have reactions or anything to add on to that in terms of how you guys at Siftwell are really helping plans address some of the member retention issues.
Yeah, Mary, I wish I had a policy wand to fix some of the state federal issues, but we're doing what we can in our small corner of the world. This is a very big deal for some of the plans that we're working with. In particular, we had the opportunity to work with an ACAP plan. They were experiencing very high levels of voluntary disenrollment. We ran a number of different models to understand who was going to voluntarily disenroll, go with a different plan. And then going back to some of the topics that Eben and you were covering is like, well, why? Why are they leaving? And within the observable data sets that we had from the plan, which included call logs, customer satisfaction, a bunch of other information, we were able to identify several cohorts of individuals where the plan could take action, begin to develop some campaigns and run those. I'll mention one specifically. One of the things that we observed a strong causal relationship between was members that availed themselves of some of the covered benefits that they wouldn't traditionally use. And so not entirely center the bullseye for our conversation today, but I think the results do speak for themselves. They basically launched a campaign to build awareness around some of those covered benefits. And over the course of the year, we monitored that campaign and their touches to those members around those covered services. And as a function of annual enrollment, what we saw was a 14% lift in the number of people that stuck around with that plan. That some of which is, or most of which, we're not sure yet, is attributable to them building awareness around the rich set of benefits that plan offers. And I do think there's a very serious opportunity for MLTSS plans to run something similar. But it wasn't just limited to that one. Eben, I see you smiling, so I want to give you a chance to jump in on this one if you want.
No, I think what is interesting, just to kind of add on to that, with these campaigns, we're obviously collecting a lot of data as case managers are interacting with these members. So we were very fortunate to work with a team that was very diligent in collecting call log information, summarizing their conversations. And what we did is look at all these notes being collected about these conversations during the outreach. And we essentially took those notes and turned them into psychographic models where we could then try to predict who feels a certain way about going for a cancer screening. And the case managers could essentially rank order their outreach efforts to focus on the people who are likely to be friendly, people who are likely to be positive to the message, people that were persuadable to go for a cancer screening. And because of that psychographic modeling, because of that human in the loop data collection process, the collaboration between the human and the machine, we also saw a significant lift there in that quality measure. So again, very interesting use cases here. And again, it just comes down to effective explainable AI combined with humans in the loop, leading to these effective outcomes that address some of these hard to observe statistical drivers.
Yeah, thanks for that, Eben. Mary, the other one that I wanted to see, and I'm throwing you a little bit of a curveball here, so forgive me that. But risk of institutionalization is also a very big deal. Anything to add there? Because I also wanted to share some of the work that Eben's been doing around that issue. But I don't mean to put you on the spot here, but you're probably familiar with this one.
Yeah, of course. Well, and this is something that is inherently built into most MLTSS programs, right? Is the desire to move people from the institution back into a home and community-based setting. That is where most older adults and people with disabilities want to be. They want to be in their homes and in their communities and not in institutions, and to avoid those risks of institutional stays. It's also really built into a lot of MLTSS plan contracts with their states, right? Their state partners are expecting a certain number of people, right? When you launch a new MLTSS program in the state, those states are expecting a certain number of people who are in an institution to be transitioned back into the community. And so that is like an inherent part of the MLTSS programs and MLTSS plans is their need to be able to avoid institutionalization when it's unnecessary, right? Unnecessary institutionalizations and costs. This also plays into what I was talking about a little bit in terms of the challenges with the policies in terms of the unalignment of benefits when the MLTSS plan may not be responsible for the healthcare spend or the Medicare dollars. They may not be responsible for that hospital stay or that SNF visit, but they are certainly responsible for that Medicaid stay. And so this is something that states are increasingly asking plans to be able to address is institutionalization, getting people out of institutions unnecessarily and to avoid unnecessarily hospitalizations and inpatient admissions as well.
Yeah, that's helpful, Mary. In the work, just briefly, the work that we're doing in this space, we've got a plan partner that's working with complex populations, and they've asked us to look at this kind of from 3 points in time. One, study trajectories or patterns where folks are, where there's opportunity for diversion. And so who's likely to be institutionalized? How do we think about them? And what are the supports and services that we can wrap around them or that their data twins have in order for them not to end up in that setting? Once they're in that setting, how do you think about the transition back into the community? How do you support and accelerate the velocity of getting them out of that setting back into the community? And then probably most important is how do you make sure that they're successful post-transition? Where are we seeing success? Where are we seeing folks wash out of those placements and return to an institution or some other unwanted setting? And then contextualizing all of them for the folks that are working directly with them, whether that's on a person-centered plan or their care manager or their navigators, whoever that is, making sure that there's alignment between the individual member and the associated needs, and that frankly the plan is aligning the right set of resources with their membership kind of at the higher levels. And so very, very cool work that we're excited about doing. Eben, anything to add there? Because you're deep into that one right now.
Yeah, it's a very interesting project. I mean, we'll go into details. I don't want to be too specific, but what's interesting about that project is that there is a very strong connection between mental health, physical health, and then also SDOH drivers. So for example, in the group that transitions to the community, the ones that tend to have adverse outcomes tend to be associated with chronic conditions like diabetes, for example. And specifically diabetics that move into environments that are associated with higher crime rates and other potential indicators of lack of social support. And being aware of these individuals and knowing that they need more attention once they transition to the community, investing potentially in other types of infrastructure to help them, have more success when they transition. Those are the kinds of projects that we like to work on. But I just wanted to call out that intersection between those three different areas, which is a very big explanation for the success of these members when they transition to the community.
Yeah, I think it's good, Evan. The other thing to point out is some of those things might sound like motherhood and apple pie or super obvious. I think the difference is being able to pinpoint Evan's at higher risk for not being successful back in the community for these following 3 reasons versus Trey's following 3 reasons, and they're rank ordered in different fashion so that folks can, so it's contextualized, and so that the individuals working with those members know what's most important in terms of those supports and services. So,
yeah, and I might want to just very briefly add something that, with these types of programs, the data usually is all over the place. It's very scattered. It's a mess. There's an Excel spreadsheet here, and someone has a file somewhere over here, and there's an email with a text document here. So we want to make it very clear that we work with our clients to absorb all that data in the way you currently have it. And we acknowledge that sometimes it's very scrappy to kind of stitch these pieces together. But it really is extremely powerful when you can combine these different data sets from different sources and different field notes and so on to feed into the central model in order to have a better outcome.
Okay. Good, thanks for that, Evan. All right, I'm gonna go to questions, and folks, if you got them, this group loves to be conversational. So there's one about value-based arrangements. Yeah, so some of this technology can be absolutely used for that. Mary, do you want to add anything on that topic? And then I can talk maybe a little bit about what we're up to, how important is that issue? We've seen it nationwide, and then I can kind of talk a little bit about what Siftwell is up to, if it's relevant.
Yeah, definitely. I think within value-based care, this is in value-based contracting. This is something that we're increasingly working with MLTSS plans, because more and more states are asking MLTSS plans to have a certain, perhaps they're saying a certain percentage of their contracts have to be in value-based contracting or value-based care arrangements. And value-based contracting is so different within the MLTSS populations, right? So there are several unique challenges within value-based contracting within an MLTSS population. And one of those is just defining value for this population, right? So value definitions vary depending on the populations you're serving, their needs, and the type of care. And LTSS beneficiaries are a unique population with a particularly complex set of needs and conditions. And so value looks fundamentally different within these populations compared to some other managed care populations. They really need to balance the traditional cost savings approaches with maybe some more non-traditional goals of improving quality of life and other person-centered objectives. Cost savings outcomes from LTSS value-based contracting may lead to an unaccrual of savings to unaligned entities, right? So we talked about that challenge earlier with dually eligible consumers. And again, I spoke about this a little bit earlier, but since there is this limited agreement on a standardized set of quality measures for LTSS, I think many MLTSS plans and providers are struggling to navigate this space with such a unique population without more guidance from states or without more understanding of a universal set of quality measures to be working towards. And we've also heard a lot of challenges around data infrastructure and analytics around value-based contracting. With challenges related to the data required to develop and inform, there is a thought that the data required to develop and inform these value-based arrangements can be inherently complex and costly and hard to find, and that you really need the infrastructure in place and the data to meaningfully develop, report, and evaluate value-based contracting arrangements within the MLTSS program.
That's perfect, Mary. Thanks for the context on that. That helps me orient some of what I'm about to say. I mean, the cool thing about some of this technology is that the machine learning allows us to basically put members into, I'll use the word vintages, but that's not the right way to say it. I mean, essentially what we can do is identify complex relationships and patterns, claims, admissions, everything else. And then we can look and say, all right, people that look identical in every observable way, this is what their pattern looked like in 21, 22, 23, or even going back further than that. And we can develop very stable, and in fact, we only pull the really stable ones for our plan partners, but very stable patterns in whatever it is that we're trying to address, whether that's cost, disenrollment, admissions, quality scores. And what we could say is, of this 340 people, this 275 people, this is on average what their admissions to an emergency department look like, or an inpatient look like, or this is what their quality scores look like. And they're very standard distribution curves. And what that allows our plan partners to do is actually take that information, go to a third party, and whether that's clinical in nature or not, they can say, here's how we want this curve to look different, and we'll pay you accordingly. So even something as simple as like, how many people do I want to get to a wellness visit on an annual basis? Like if only 64% of my members went for that last year, and it was pretty consistent the previous 3 years, how do I get that up to 80%? And vendor, I'm going to pay you for executing on those results. Or maybe that's member retention. But how we work is equipping our plans with very specific information about who to target and what they're trying to move, and by how much. And then they can essentially go out and buy that, if you will, by way of one of these alternative payment arrangements or value-based arrangements. So, Eben, I see you nodding quite a bit there. Do you want to talk about that?
Not much to add there.
Okay.
Yep. Just agree.
All right. Two other ones that I think I can pull together. How long does it take to get up and running? And then also, many ACAP plans are new to D-SNPs. Can you help new plans even if they don't have a lot of data yet? So on the first one, we're up and running pretty quickly. Again, we take data and we take it in plans native format. So from 0 to about 90 days is when we're producing full predictions. There's also the interim step, which usually happens certainly within 45 days, but generally within 30 days, is the situational awareness. Where are your members? What are they facing? And how to really get your arms around those members. And then from there, usually what we've already done is set out the use cases that our plan partners specifically want to engage in or improve, but also that situational awareness step gives us more threads to pull on and drill into some more focused areas. The second part of the question, can you help new plans that are new to the space or have new members? The answer is yes. Because of the additional data sets that we pull from outside of plans, we're actually able to take new members that have similar characteristics, even without similar claims patterns, and map them not only to all the SDOH factors, but to people that historically have looked like them. Again, you always got to keep the human in the loop, but what it does is it gives you a really good starting point for thinking about new members as you're onboarding them, about who to get first to some sort of assessment or who to get assigned to care managers, navigators, complex care managers, nurses, whoever it is. But the short answer is absolutely, and we've had some really good success in there. The other thing that was interesting to me, having run a plan, this is a super simple one that Eben showed me. Pharmacy settles at point of sale. Most pharmacy settles at point of sale. And so you have instantaneous claims about the types of drugs and drug classes that people are using. When I was running the plan, we didn't use that. And that's now a super obvious thing. If they're using particular drug classes, then what that should signal to you in real time is those are folks that you need to get connected. And that's only one really specific example of how new member information can actually be really powerful in terms of how you prioritize. The last thing I'll mention on that is this is actually I pulled from an old slide. Hopefully this doesn't have any plan specific information on it. Let me maximize that quickly before anybody sees anything. This is a non-MLTSS plan. I want to make sure I say that though. But essentially what we did is we took 1 month of claims data, which again was very heavily pharma driven, and then all the environmental data sets that we had to stitch together with that one month of claims information. We said, pay attention to this one cohort, and then apply normal procedures to the rest of your population. At the end of that first month, they were nearly indistinguishable by way of their care costs. So $71 versus $181, and there would have been a lot of crossover between those two groups. But when you fast forward to the end of the year and you look backwards and say, how did Siftwell's identification of this specific cohort of individuals compare to the broader membership? The members that we were able to identify and say to the plan, pay attention, cost the plan on average of $14,500 versus the ones that we said apply normal protocol to, which was $3,300 essentially. And so the short answer to the question about can we do some good work with limited data, the answer is yes in that case. So, Eben, anything to add there?
Yeah, I might want to add very briefly that usually with pharmaceutical claims, you can also see who the prescribing provider is. So what we do on the back end is we actually have a proprietary social network, essentially, that we're building, where we know that this member interacted with this care provider. And these two care providers are likely referring, members to each other and connected geographically and so on. So on the back end, once you know what the pharmaceutical prescription is, what the effects are of that drug and who the doctor is prescribing it to them, there's just a wealth of extra metadata that you can extract from that initial set of data in order to inform that likely trajectory for that individual over the next 12 months. But again, early on, we generate confidence intervals for these predictions. So in general, after a month or 2 months of claims, it's not a massive volume of claims. So the confidence intervals tend to be very wide. But then as time goes on, the models become more confident in their assessment of the risk of these members. And again, that's part of the campaign tracking that we do. Within the first month or two, here are your at-risk members. And then as time goes on, we validate the model's predictions in order to establish, whether there are certain areas that need to be prioritized for outreach.
Awesome. Thanks for that, Eben. All right, so we've got about 10 minutes left. I'm going to keep monitoring the questions, but what I'd like to do is transition and would love to give Mary, Eben, Christine, if you want to avail yourself of it, kind of a last thought or a parting thought for the folks that have joined us today. So Mary, do you want to kick us off?
Sure. Yeah, I just again want to thank everyone for the opportunity, and I certainly learned a lot during today's discussion and webinar. We know, as I've talked about, like MLTSS populations and dually eligible populations are really complex populations, and as such, or sometimes it's sometimes harder to implement some of these solutions or other interventions that have worked in a traditional managed care setting or in other healthcare settings. But it's really exciting to see solutions like what you all have as opportunities to really support MLTSS and MLTSS plans and D-SNPs. And I'm really just thankful for the opportunity to work with you all and to partner with ACAP and all of our member plans to help advance the industry here.
Awesome. Thanks for that, Mary. Eben, do you want to go?
Just thank you to everyone for the time. I really enjoyed the session. I think for me, the biggest takeaway is that every plan is unique and every population very complicated with very specific nuances that need to be taken into account. I think it's a big mistake just to take some off-the-shelf machine learning model that's just based on correlational predictions and recommending, next best actions from a model that's not tuned to the unique characteristics. These models need to explain why they're generating these predictions so that we can become aware of potential biases, have a human in the loop to monitor these predictions and these focuses, and then use the causal AI frameworks that have recently been made available to the industry in order to do effective intervention and effective modeling of what's actually the core reason for driving the outcome and addressing the problem that actually matters in moving the needle, and then keeping everyone accountable as you track the progress on that campaign towards providing better care for these members.
Awesome. Thanks, Eben. Christine.
So I just want to say thank you all. This was such an incredible session. I'm really glad that the audience got to hear more of the work that Siftwell does, and then also just really your perspectives on all of these various issues related to D-SNPs and duals and MLTSS and integration. And just a reminder for everyone in the audience that there's more information about our preferred vendors. You can contact Siftwell if you'd like, also through our website, communityplans.net. Also on our website, you'll find all of our policy and operational support work related to D-SNPs and integration MLTSS. So just want to let you know that that resource is available to you. And thank you again.
Thanks, Christine. I'll wrap with just a PSA. It doesn't have to be Siftwell, but what I would say is encourage all those out there in the ACAP universe to start thinking about AI, even if it's something as simple as voice to text for your care workers. This stuff is very real. I've gotten a chance to see it kind of in a front row seat, know the applications of it. So start to figure out how to get cracking on AI. I recently saw kind of I think it was a meme, and it said, you know, AI isn't going to take jobs away from humans, but humans that use AI are going to take jobs away from those that don't. And the same, I think, is true when I think about plans. And I think one of the most important things that our country has for our overall health ecosystem is our safety net plans, our not-for-profit, our governmental plans, our quasi-governmental plans that are covered by Mary's organization and by Christine's organization. We've seen where that set of plans has gone away in other states and they don't come back. I think states are thinking a lot more about AI. We're seeing it show up in RFPs. And when you look at the machinery that large plans have for responding to those RFPs, they're just outgunning some of the smaller plans. They outgunned my plan when I was running it. And so I think this is a really important thing for folks to get their arms around. This isn't a wait and see type technology. I think when we think about the AI revolution, it's going to be bigger than all of the other revolutions that we've experienced in this country, with the exception of the American Revolution. But take the industrial, the information, you put them all together, and this stuff's going to be bigger, fortunately or unfortunately. And I think there's a real application for it in the healthcare space to make members healthier, make communities stronger, and make plans more successful. So if you're out there, you're listening, and you're a plan, get cracking. And if you want our help with some of the things that we do, we'd love to talk to you. And if you need help with some other area of artificial intelligence, we can get you introduced to folks that know how to do this stuff and can be trusted partners to you all. So I didn't see any more questions come in. So with that, I will wrap and just say thanks to Christine, to Sherry. You guys did an amazing job getting this organized. Mary, thanks for jumping in and offering your expertise. So I appreciate everybody. Take care.
Thanks, Trey, for that wrap up. That was terrific. Just as a reminder, today's session has been recorded and will be on the ACAP website as Christine referenced, communityplans.net. Just go to the event page and you'll find it there. Thanks, everybody.
Thank you. Happy Monday, everybody. Bye-bye.